Thank you, Professor Shadi, again, and I want to apologize for Professor Dr. Dina, who shared Dr. Ahmed, I think, for the success of these events annually or regularly. Dr. Dina is a well-known now professor of clinical oncology in Shamsi University. She shares the success of Shamsi University conference. She shared the BGICC conference with Professor Hisham, and I think she shared you all the success of the previous 6 events, and I wish her all the success in the coming events. Now it's my deep pleasure to introduce my dearest friend and brother, Professor Ahmed Magdi. He's Assistant Professor of Medical Oncology, NCI. He's going to talk about early HER2 positive breast cancer.
Thank you for the beautiful introduction. Thank you, Professor Ahmed. Thank you, Professor Dina, for inviting me to be the speaker. I have a tough talk now because I'm talking after Professor Shadi, who showed us the HER2 and the problems with the pathology. Now I'm taking you to the early setting in the clinical setting. So these are my disclosures. And to start with, expression of HER2, we have to understand that HER2 expression actually is normal. I mean, we do have HER2 overexpression on our cells, or nearly all the membranes of our cells. However, as Professor Shadi showed us, we measure the overexpression, and this is what we target in HER2 positive breast cancer. And actually, nearly all breast cells, they do have a HER2 expression. So HER2 is normally present, and it's not a mutation that occurs during the development of malignancy. Definitely this slide is super old because Dr. Shadi showed us everything, but this is just to show you that the interpretation of HER2 is now changing, and now we are implementing the ultra low, the low, and the equivocal. Now we have to dig deeper when we hear equivocal. Also, historically, the prognosis with HER2 positive breast cancer is always bad. I mean, whenever you find a breast cancer with HER2 overexpression, then we're talking about an aggressive disease regarding the disease-free survival and overall survival. However, this has changed with the targeted therapies. And what we do have right now as targeted therapy for HER2, we do have a plethora of drugs that has been approved, as you can see, whether you target the outer part of the HER2 receptor or the inner part where you need smaller molecules to infiltrate the cell membrane and go target, like the delapatinib, the neratinib, and tucatinib. They do attack the inner part of the receptor, while the trastuzumab, margetuximab, and the pertuzumab, so pertuzumab actually binds and prevents the heterodimerization. It was discovered that HER2 overexpression leads to receptor activation, but they found out that half of the receptor of the HER2 can bind to another half of other HER3 receptor, leading to stimulation, and this is called heterodimerization. So pertuzumab prevents the heterodimerization. So let's go to the neoadjuvant settings. And why are we talking even neoadjuvant? Why are we giving neoadjuvant? Because we need to reach pathological CR. What is the importance of pathological CR? Let's see together. So actually, pathological CR has been proven that it's a surrogate marker for overall survival in breast cancer, and it improves the long-term response. It de-escalates the post-operative treatment. So if you give all your neoadjuvant and achieve a pathological CR with the neoadjuvant, then after the surgery you don't need to go further with your targeted therapies, or with chemotherapies and so on. Also, neoadjuvant can convert the advanced surgery and leads to breast conservation. So neoadjuvant is important. What are the pivotal studies for neoadjuvant trastuzumab, pertuzumab? You can see here that we do have the NeoSphere, the phase 2, and the Trifina trial, which are very famous trial looking at, for example, the trastuzumab Herceptin, which is the Herceptin, for 4 cycle surgery, and then you continue with FEC. This is the neoadjuvant, and this has been obsolete. So when you give the neoadjuvant, it's better to give all your neoadjuvant up before the surgery and please abandon the sandwich technique that we used to do before. Why? Because you get the maximum response, you achieve a better pathological CR, and you avoid the post-operative further treatment. The Trifina trial, again, looking at giving everything before the surgery, and this has been proven by combining the pertuzumab with trastuzumab, achieving pathological CR. And as you can see for the NeoSphere, the pathological CR actually is now achieved by pertuzumab, trastuzumab, docetaxel. And I quote the speaker last ESMO said, "It's a crime to give anthracycline now to patients with HER2 positive neoadjuvant breast cancer." And he stated that clearly during his session. He said, it's a crime now to give anthracyclines for those patients, because historical data have shown us that when you have a HER2 positive, when you give them anthracycline, you get a better response. But this was an old data. Looking at the Trifina trial, with the cardiac safety and cardiac toxicity and the rate of pathological CR, you will find that you achieve that with the TCHP, and it's the highest pathological CR, as you can see at the end of the table. That's the highest response with the TCHP regimen, avoiding the anthracycline and the cardiac toxicity. What do we have for the future? Ongoing trials in the HER2 positive. We have the 𝐶ATLIN trial, the IMPASSION, the APT-NEO, and so on. By implementing more drugs in the neoadjuvant settings, for example, adding the immune checkpoint inhibitors, adding the CDK4/6 as part of the neoadjuvant regimen, but again, we're still waiting for further results. Federica looked at the comparison of what we do have now is the subcutaneous pertuzumab, trastuzumab versus the IV. And is there a difference? Actually, they found out that so you give a fixed dose of the subcutaneous injection of the combination of trastuzumab, pertuzumab versus what we give usually by IV related to the body weight. And they looked at this, and it was found that the fixed dose of subcutaneous combination of trastuzumab, pertuzumab actually was non-inferior to the IV, easier in administration, and the same outcome. So now it became the standard of care. However, with all what we've been saying, only around 50% of those patients will reach the pathological CR, as you can see from all the NeoSphere, the Trifina, the 𝐶RISTINE, and so on, all the trials available. So they started looking at, again, this is to show you that why the professor in the last ESMO said it's a crime to give the anthracycline, because they compared the TCHP with what we had to give before, with the anthracycline inclusion, and you can see that the rate of pathological CR is equal. So we avoid the cardiac toxicity, we avoid all the hassle of giving the anthracycline, whether it's extravasation or the long-term cardiac toxicity. And I believe I've seen, from my share, I've seen 2 patients with dilated cardiomyopathy during their follow-up and longer follow-ups because of the anthracycline given, and they were young actually. So again, looking at the guidelines, what if we achieve a pathological CR? You continue your initial treatment given. However, we'll talk about that. Okay, let me say it here. So if the patient does not achieve a pathological CR, then you are obliged to change your targeted therapy. Why? Because it has been shown when you switch the targeted therapy to an ADC, an old ADC that we're used to give, which is the TDM1, you achieve again a better control or invasive disease-free survival for those patients. But we cannot mention all this without saying what was mentioned the last ESMO, because we all know that trastuzumab deruxtecan, which has been gaining ground in the metastatic setting and in the HER2 low, now has jumped actually to the neoadjuvant. This was addressed in the Destiny Breast 11, and this was neoadjuvant trastuzumab deruxtecan followed by paclitaxel, trastuzumab, and pertuzumab versus the dose-dense AC-THP. And this was reported in the last ESMO last year. So these are the 3 arms, and if you look at the lowest arm, which is TDXD alone, it was closed prematurely. Why? Because because independent data monitoring have shown that it's inferior actually to the dose dense, and the rate of pathological CR was way low, so they omitted this arm. And they went to compare the TDXD for 4 cycles, followed by THP for 4 cycles versus the dose dense AC THP. Also, if you look at the hormonal status and nodal status, they will be well balanced, because if you want to look at the subgroup analysis and compare the demographics, you will find that both arms were equal in the aggressive form of breast cancer. And if you look at the intention to treat population, meaning all included patients in the trial, you will find that there is an improvement of pathological CR by a delta difference of 11.2%. So you improved the pathological CR rate, which again, we all know that it will be transferred into a better overall survival later on and disease-free survival. In the hormone receptor positive, you get the best response with a delta difference of 9.1, but with hormone receptor negative, this is the better response with 16.1% rate of pathological CR. So all comers, 11.2, hormone receptor negative, HER2 positive is 16.1. So we have improved the rate of pathological CR. Residual cancer burden, in the intention to treat population, again, you get a delta difference of 12.2%, which indicates a better response using the TDXD as neoadjuvant. I'm sure after I finish this presentation, you will attack me and say it is a very expensive drug. I'm showing you the data. I'm not convincing you to use it as neoadjuvant. Hormone receptor positive, again, actually the residual cancer burden was definitely in favor of the hormone receptor positive, with a delta difference of 13.3% versus the hormone receptor negative at 9.2%. Event-free survival, you can see definitely that with a 2 years follow-up, you get an improvement of 3% in the event-free survival, and this is still too early to judge. We need longer follow-up. However, you can see that the hazard ratio is impressive at 0.56, meaning 44% of your patients will achieve this beautiful event-free survival after 2 years. Don't forget, if we're talking neoadjuvant, you need longer follow-up to see better separation of the curves. Because we've seen with the CDK4/6 inhibitor as adjuvant, you needed 7 years to just show a delta difference of 4.3%. Treatment adverse event, of course, we do have an adverse event related to the TDXD. I'm not saying it's the beautiful angelic drug. It has its own side effects. Again, they did a subgroup analysis looking at only using the TDXD, which the arm that has been closed prematurely, and they found that there was a trend towards event-free survival, but this arm was shut down and not continue. But the rate of pathological CR was 67.3%, more than 2/3 of the patient achieving pathological CR. Looking at the adjuvant setting, we all know that the adjuvant from the HERA trial, the old HERA trial, the BCIRG, the NCCTG, showing that the trastuzumab adjuvant treatment in HER2 positive, yes, it improves the disease-free survival and overall survival with HER2 overexpression. However, looking at the affinity trial, so if your patient, we all know, neoadjuvant, if you get a patient with HER2 positive, please go for neoadjuvant because the pathological CR is the best approach. However, previously, and this is an old trial in 2017, looking at if the patient underwent surgery upfront and she's HER2 positive or HER2 positive patient, then you give trastuzumab, pertuzumab versus trastuzumab placebo. And if you look at the 8 years, see, this is what I'm saying. You need longer follow-up to just see some improvement. So after 8 years, you can see that there is a different delta difference of almost 3% in the favor of the invasive disease-free survival in favor of the pertuzumab trastuzumab. But I didn't mention that here. If you go dig deeper, it was in the subgroup analysis of node-positive patients. So if your patient is undergoing surgery and she's invasive component is HER2 positive with negative lymph nodes, don't add the pertuzumab. And this is mentioned in the guidelines. So you give only the trastuzumab if you do have lymph node. Sorry, it's going by itself. انتوا قلبتوا من عندكم؟ غالبا دكتور خالد عامل الحركة دي فيا بس اوكي. Okay, خلاص. Okay. So in the subgroup analysis, the lymph node positive, those are the ones that improved the invasive disease-free survival by adding the pertuzumab. Why? Historically, we all know the lymph node positivity is a high risk of those patients. But then again, remember when I said if you don't achieve a pathological CR upfront, if you give the combination of TCHP, then the 𝐶ATRIN trial showed us that what if the patient did not achieve a CR or had a residual disease after surgery, then they divided the patients to an arm receiving T-DM1, which is an ADC, an old ADC, versus trastuzumab only. And you can see the invasive disease-free survival is way better with the separation of the curve in favor of the T-DM1. And now it has been confirmed and added to the guidelines that do not achieve pathological CR, you give the T-DM1, and actually this has been implemented in our local guidelines in the management of our patients. Overall survival, again, it's a mediocre overall survival, numerically good, statistically non-significant. However, the distant recurrence was in favor of the T-DM1. So overall survival, maybe the longer follow-up, we'll see later on. What about the neratinib? So neratinib is an oral anti-HER2, and this is actually given for 1 year after you finish the trastuzumab treatment. Does the neratinib addition adds? Actually, yes. For hormone receptor positive, neratinib has an improvement of invasive disease-free survival by 4.4%. However, in hormone receptor negative, it does not add anything. Keep in mind, neratinib has side effects, long side effects, toxic side effects, diarrhea, and so on, for a patient who is supposedly cured. So you're convincing your patient to receive a treatment with side effects to improve by 4.4%. But again, guidelines are there, the drug is effective, yet don't forget you are managing a patient who is cured from cancer. 5-year invasive disease-free survival, as you can see, in the hormone receptor positive, less than 1 year. If you started early, you should start it really early after the trastuzumab, you do get a better response. I think we mentioned that. These are the so these are the future. So if looking here, if you give the T-DM1 plus tucatinib, which is again an oral anti-HER3, looking at just giving T-DM1 and tucatinib, these are ongoing trial. All these we are trying to improve the response to our patients. But just for the sake of debate or the sake of discussion, looking at those trials, don't forget we're adding toxicity. So is it worth it to add those drugs to the standard of care that we do have? Always remember your patients are important and the toxicity is very important to be put in mind. What do we have as future direction? Whether you add the trastuzumab, the atezolizumab, adding the immune checkpoint inhibitors up front. We all know from the Keynote 522 that when we added in the triple negative, the pembrolizumab, we achieved a marvelous improvement in pathological CR rate in a triple negative, very aggressive disease. Can we achieve that in the HER2 positive? Only the future will tell us. Again, looking at the last ESMO, trastuzumab deruxtecan versus T-DM1. So we all know trastuzumab deruxtecan has killed the T-DM1 in the metastatic setting with a beautiful separation of the curves and a marvelous improvement of progression-free survival and overall survival. What if we added upfront, as we see the 𝐶ATRIN trial, those patients who did not achieve pathological CR, we added the trastuzumab deruxtecan versus the T-DM1. And again, we have a clear winner here, that the T-DXd is better than the T-DM1 with a delta difference of 8.7%, and this is only at 3 years. I believe when we do a longer follow-up, we'll see a better response and an impressive hazard ratio of 0.47. Again, with a longer follow-up, you get total events way lesser, 102 for the T-DM1 versus only 51 for the T-DXd. CNS metastasis 17 versus 25, and so on. You'll get, and the disease-free survival is way more better in favor of the T-DXd. Too early to judge the overall survival, but as you can see here, you can see that there is a trend regarding the brain metastasis-free interval, which is the BMFI, the distant recurrence-free interval, and the overall survival. Yes, you can see a trend, but time will tell us for the future. And their conclusion at that trial was 53% reduction in the risk of invasive disease, recurrence, or death. Looking at the guidelines, you can see the TCHP is the preferred option. You don't see the anthracyclines here. This is the preferred. Yes, it's there if you go down the guidelines, but now the preferred option is TCHP. Add trastuzumab emtansine, which is the TDM1 if the patient had a residual disease, or trastuzumab deruxtecan has been approved by the NCCN guidelines, and this is the most recent guidelines, and thank you so much for listening.
Thank you, Professor Ahmed. Just I have 2 comments or questions, or name it whatever you want. Tucatinib, I think it's now widely used nowadays in Egypt, so it's not under trial as you mentioned.
You mean the TDM1?
Yeah.
Okay.
Okay. This is the first comment. The second comment.
No, I'm sorry. Can you repeat this one? أنا اتلخبطت أنا آسف.
Tucatinib nowadays.
Tucatinib.
Yes.
لا أنا بتكلم Tucatinib في ال early setting مش في الميتاستاتيك.
Yes.
لا,
yeah.
in the early setting.
Okay.
Now it is approved for HER2 climb. Already we're using it.
Exactly.
Yes.
Okay. The second comment, now in 2026 we still have patients HER2 positive and looking at advanced and operator, and they're coming for an adjuvant treatment. And as you stated, anthracycline is a crime nowadays for HER2 positive. I think it's the same crime. And also some patients, that's the surgeon, and I wish that surgeon could be with us today. The second part is the patients. Many patients, not most of the patients, unfortunately discontinued the neoadjuvant and going for their promising surgeons for surgery, and they are not continuing the neoadjuvant and coming post-operatively for the adjuvant. That's why you cannot comment about the PCR for such patients. So I want just your input about these 2 points.
So for the Tucatinib, yes, it has been used already in Egypt. We've been using it in the HER2 climb, but I mean in the early setting. So we are trying to improve the outcome with the HER2 positive, because we all know that HER2 positive is aggressive. It comes with CNS relapse. Very common, it comes with CNS relapse. We didn't see that before, but with the improvement of survival, now we see that, and we knew that. So this is for the Tucatinib. The future only will tell us. For those patients, again, I will differ a little bit here, because some of the surgeons now are referring those patients with HER2 upfront for neoadjuvant. They don't touch the patient. Okay? And this some, أنا قلت some. عشان برضه ما فيش جراحين قاعدين، بس عشان انت عارف معاهم مشارة حضرتك وبتبقى المشكلة صعبة يعني. بس قصدي اقدر اقول ان in general ابتدوا يحولوا او ابتدوا يقتنعوا بالنيو adjuvant and achieving a pathological CR. Yet زي ما حضرتك بتقول in 2026 الاسبوع اللي فات عيانة برضه going up front for surgery، والحمد لله طلعت node positive، يعني قصدي كانت heavily infiltrated and they went for surgery up front and she's HER2 positive and coming to me now to tell me what shall I do. adjuvant انا ههجم بكل حاجة. للسيرجنز في النيو ادجuvant علشان خاطر to increase the referral rate to us.
Cross talk between oncologists and other specialties including surgeons is very important. برضو أذكر حاجة، يعني الدكتور كمال الغمراوي لما كان رئيس قسم الأورام في القصر العيني كان عامل بروتوكول teaching oncology to surgeons and to doctors non-oncologists، يعني النساء يعني الشيست يعني. فالحقيقة دي كانت مهمة جدا لأن كانت بتجيب لنا حالات كتير، يعني الريفيرال كان بيبقى أكتر وعلى on good basis. فالحقيقة this is very important cross talks.
وعايزين نبلغ الجراحين إن إحنا هنمضي تعهد إن هنرجع له العيان تاني.
أيوة بالظبط.
طيب.
Any questions?
في questions. Yeah.
كانسر في البريجننسي وومن فايه الحل هنا لما اجي يعني انا عندي بريجننس وومن وهي عند وتقريبا الدواء بلاد برين بارير فهيعدي بلاسنتا، فايه الحل اللي ممكن اعمله مع بريجننس وومن معاها مثلا بريست كانسر؟
اوكي، لو حضرتك بتتكلم على انهي دواء فيهم؟ اللي هو الترستوزوماب ديروكسيتيكن. طيب الترستوزوماب ديروكسيتيكن ما اعرفش correct me if I'm wrong, it does not pass the blood brain barrier. الوحيدين اللي بيعدوا هم السمولر موليكولز زي اللاباتينب اللي هو الاورال انتي HER2 القديم بتاعنا بتاع زمان، لان هو it's very small, it attacks the inner part of the يعني كل اللي بيوصلوا للinner part of the receptor دول اللي يقدروا يعدوا البلاد برين بارير. however trastuzumab deruxtecan I don't think to my own knowledge بيعدي. خلاص دكتور خالد بيقول انه بيعدي فعلا. ف anyways انت in general these are not كلهم teratogenic in general، لازم تبقى حضرتك عارف كده. if you have a patient that is pregnant with in the first trimester you are not allowed to give anything ولا كيمو ولا targeted ولا اي حاجه خالص. okay if we bypass the organogenesis part اللي هو first trimester then you are allowed to give chemotherapy and the baby will develop normally. For the targeted therapies like trastuzumab again they are teratogenic and you should not give. So for those patients you should do a medical abortion and then continue the treatment.
Okay, thank you doctor.
Okay, thank you.
Thank you دكتور أحمد.